The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
Wow, I'm really impressed that so many of you have come to listen to a bureaucrat, but I'm a technocrat first and a clinician first, then a bureaucrat. But essentially what I wanted to talk to you today was what we've actually learnt in Victoria about deteriorating patient through the critical care clinical network. And I guess what we wanted to do was really listen to our sector, being public and private RCUs, about what was important to them, and therefore take that up and do something meaningful with that. And so we engaged Norman Swan in the middle there to talk to over 200 clinicians who told us basically, yes, we were right. The goal for the network was really around safe, timely and appropriate critical care. But more importantly, we asked people to vote on the priorities, and that's what's circled down the bottom there. And so the first priority that people identified was standardised guidelines. It's a little bit of a sad state, but certainly we can do much more in this space, and we are doing that. But what I wanted to talk to you about was the other priority, which was the MET rapid response. And so we absolutely concur with what the sector had told us, because in 2014-15 there were more MET calls recorded in Victoria with an ICU than patients admitted to ICU. I did some maths with Daryl Jones around that, and for the 41 or 40 ICUs that reported alone, not the 86 health services in Victoria in total, but out of that cohort, a MET call was happening every 15.9 minutes. And I think if we accept what the literature tells us, that approximately 18 to 20% mortality that sits around that, you know, that's a lot of people in need, and certainly it's a whole stream of work for our ICUs. So what did we do? We did two things, and I'm going to talk to you about those. One was we really needed to put some really robust governance around that, and the other thing was we needed to provide people with the opportunity to do quality improvements. So from a governance perspective, we asked the sector to be involved in a subcommittee specifically, and this subcommittee was charged with two very important things. One was, what's the problem we're actually trying to solve here? We know there's a big vague problem, that is that there's more MET calls than patients being admitted, but what is the actual problem? And I don't know whether you agree with that or not, but certainly Daryl and Tali and the rest of the group thought that it was really about a demand that was really being overstretched and potentially maybe inconsistent across the system. So what were we going to do about that? Well, certainly what we could do within an ICU remit, but I think what we've done since then, our aim is much more systemic. So one of the actions that the subcommittee wanted to do was to quantify, and we did that through a survey, and mostly senior nurses responded to that survey, and particularly over 60% were regional as well. I think some of the things that really stand out from this was basically around, does your MET or rapid response team receive training? And you can see just over 71% actually don't have standardised training. So that's difficult for a whole host of reasons, and there are another set of reasons as to why that doesn't happen, but that's something that we can really support. Interestingly, we said, what do you think is the best way of capturing this information as MET calls are happening? And people responded, I'm going to say electronically with Riskman. I don't know what you have necessarily here, but overwhelmingly electronic over manual, which is a great response. But, you know, moving forward, what would be your preferred option? And again, it was electronic. So this was also very interesting. We wanted to understand a bit more detail about who is actually looking at MET calls. So we understood that the ICUs were definitely looking at it and responding to it. But what the senior people that were responding in this survey were saying, that it wasn't just the Standard 9 committee and it wasn't just the ICU only, but what consisted in those other groups across both of those areas was really specific roles within ICU. So it might be the liaison nurse or it might be the nurse in charge, depending on the setting. So we thought, well, from a governance perspective across the state, that makes it very difficult for the local unit to be able to elevate the issues in their health service if it really comes down, or is it really quite person dependent. We also had lots of free text for telling us what else was really important. And this morning we heard about the people that, Charlie Cook identified that there's a really minority about whether ICU should be involved, and certainly the notion of less ICU involvement in Met Call was raised as well. So the other thing we wanted to do was actually understand a little bit further in terms of what hospitals were recording what when it comes to Met Call. And the first column is really a tertiary example. It's the only one I have that can fit on the slide here, but they collect 60 data points around Met Calls and what's actually happening. So if you look at the regional hospitals, it's quite low in terms of what they're collecting, but there is a metropolitan hospital in there that is equivalent to a regional, and certainly the other metropolitan hospital has 51 data points. I don't know what the correct amount of data points is, and I'm not expecting the subcommittee to identify that, but certainly if we think about the issues of why people are or are not engaged in MET across the organisation, then maybe we need to more clearly define what's meaningful to capture and feedback. So this is the second point, which was providing some funding to ICUs to be able to participate in a 9-month quality improvement activity specifically around MET. And I was so pleased through that expression of interest process that we got a 50-50 split between regional and metropolitan hospitals being involved. They worked really hard, and a number of them are in the audience today, but we really did a couple of structured things, and we did use the breakthrough collaborative model, and before you roll your eyes, it was very useful for this group who hadn't actually come together in this format before. One thing we added to that program was an insight to an exemplar who are doing MET particularly well, and that was Austin Health, and that was really a fantastic opportunity for people to connect in and really see on the ground how they use their data sets and what tools they have. So what was important was to understand, was that actually of value add, doing that piece of work? And the feedback actually was quite positive, and you can see Daryl was our expert that helped support that piece of work. And even if you don't have the opportunity to be part of a collaborative like this, I would strongly suggest that you partner with another health service to be able to work together, because a problem shared is a problem half solved. So what's the information that we came through? So I did say they worked very hard, and they did, and we used some frameworks, and we used the 4 Ws to help them distill that big vague problem into bite-sized chunks that they could work on. And so that 4 Ws consisted of the what, the where, the when and the who. Obviously we did look at the 5th W, which is the why, and we did do some intense problem solving, but I'll come to that in just a moment. So I think this is pretty consistent, and differ with me if you want, but most of the Met calls were happening in the acute areas, almost a 50-50 split between medical and surgical. Most of the patients remained on the ward, and the higher volume was happening during the day and right smack in the middle of the day, but overall very consistent that it was a 60-40 split between the daytime and night time when METs were happening. And so understanding this capacity and demand information is really important for matching people's models of care that they have around their MET team, because the demand doesn't necessarily go away. That varies depending on whether you're metropolitan or regional, of course. But for instance, some of our variation, one of our biggest hospitals has more than 7,000 MET calls in a year versus some of our smaller regional units that have a couple of hundred. So the other thing we did was we took liberty with the National Consensus Statement and turned it into a self-assessment. And again, please don't roll your eyes about self-assessment. But what we took was the 2 domains and split them up and made them measurable. And what you can see there is a radar graph or a spider graph. And this is fairly representative of all the health services that were involved. And it's no surprise that and you could argue that it was ICU staff doing the self-assessment, so of course they're going to respond quite well on their rapid response team and their escalation. But certainly there are some significant gaps, and if you're looking for a well-oiled system, the wheel's not fully inflated for that to happen. So the ones in red are the clear areas of focus that we really need to support people to do some more work in. This is really valuable in having a conversation back within your health service to say, hey guys, we haven't quite got our system quite right, and how can we make a difference? I'm happy to share that if anyone's interested. We also wanted to understand, did people actually make some meaningful change? And we did a project progress score, which goes from 0 to 5, all the way up to sustainable change. And while a few health services haven't submitted their final score, you can see that they actually have tracked along and made a difference. So what were the issues? Just very quickly, we divided those up into the 3 components. I don't think those issues are any different for any of you working in any context. Maybe how frequently they happen might actually be the case, but certainly I would beg to argue that, and things that I've heard today, that they are fairly consistent. So what did they do? What did some of our 15 health services do? Well, some of them it really highlighted to them around the deficits around governance. And so, you know, moving along, trying to manage MET as an ICU is quite isolating, and you really want to share that burden and really involve the hospital. So having the data, having that radar graph and being able to have those conversations was really powerful. In certainly standardising some of the responder training. So people really reviewed how they did that, and some went to the effort of doing simulation, whereas others just standardised their approach. Standardising the documentation, and I know that's a bit of a yawn, but really that was really important in terms of, okay, this is my role, this is your role on the ward, this is what we expect from you, don't run away now that the ICU team is here. And certainly the key one is the last one. I can't overemphasise that enough. You know, really demystifying that ICU can be called at any time to answer a question versus, you know, coming in there to save the day. So that relationship building is incredibly important. But what are we going to do as a government, as Safer Care Victoria? Really the next steps for us is to develop a systems approach around bringing the data much more centrally and taking the burden of reporting away from our health services, and particularly our ICU liaison nurses. So having a data repository will be really important. Also for benchmarking and supporting people with their conversations with their own internal administrators. And of course we can't get away from guidelines and having developed those. I think the other component is supporting people with home team involved in MET calls. We did have the notion where some teams just couldn't get anyone there consistently to a MET call versus others that had an amazing rate of 95% or more attendance. And certainly working with some of the key resources that are already out there and making them centrally available. So that's what we've learnt. I think for us, some of the key take home is really that we can do better, and then we want to benchmark nationally as well. So we've started that conversation and hope to do more. Thank you.